Thank you for joining us today for this educational program on California's End-of-Life Option Act. This is a new law that allows a terminally ill adult to request and receive a drug for the purpose of ending his or her life, and obviously has significant implications for physicians who are very much a part of the process in responding to requests, counseling patients, and prescribing the drugs. This program is a part of the California Academy of Family Physicians End-of-Life Conversations project, a broader project designed to support family physicians in providing end-of-life care. I'm Leah Newkirk. I'm the Vice President of Health Policy for the California Academy of Family Physicians. And more importantly, I'm joined today by three wonderful family physician panelists. We've got Dr. Peter Regan from Oregon, Dr. Greg Vandekieft from Washington, and Dr. Catherine Sundquist Forrest from California. None of our panelists have any conflicts to declare. Our goal today is to help you understand the law and what family physicians' roles and responsibilities are under the law. I'm going to start by giving you a summary of the law. Then we'll turn to Dr. Regan and Dr. Vandekieft to describe their experiences in states that have had similar laws for some time. Then Dr. Forrest will describe how she's preparing as a California physician to participate and to serve her patients. Then we'll leave time for questions at the end, and we'll direct you to resources for more information. You can scroll down to the bottom of your screen and open up a chat box there and type in any questions throughout the program, but we'll save questions for the end. The End-of-Life Option Act was signed by Governor Brown in October of last year. It was passed during a special session of our legislature, and so it goes into effect 90 days after the end of the special session. And unfortunately, there's no definitive end date of that session. So we're just waiting for that to end, and then we'll begin a 90-day countdown. The California Academy of Family Physicians was neutral on the bill, and we're not trying to stake out a position on the law now, but we do recognize that this is the law, and we feel we have a responsibility to provide education. Importantly, this law governs the behavior of physicians who want to participate and prescribe aid in dying drugs, and physicians who don't want to participate, who want to opt out. So everyone should dig in here and gain an understanding of this law. We also think this is an opportunity to highlight the role of family physicians in end-of-life care. And they do have an important role. We recognize in U.S. healthcare that palliative care, advanced care planning are areas where we can make great strides in improving quality. And we think family physicians can do that better. So we're hoping that this law shines some light on end-of-life care generally and creates that opportunity. So who's a qualified patient who can make a request under this law? It must be a terminally ill adult who voluntarily requests the prescription, who's a resident of California, and documents his or her request in a specified form, and has the physical and mental ability to ingest the drug without assistance. Just a note, there's a bunch of forms in this process, and we will direct you to them at the end of this webinar. A patient needs to make 2 oral requests, a minimum of 15 days apart, and a written request in a specified form to his or her attending physician. And that must be witnessed by 2 people who only one can be related to the individual, and only one can be employed at the healthcare facility where the individual is receiving medical treatment. There are two physicians involved in the process here, the attending physician and consulting physician, and the definition of both under the law is written out here. CAFP actually has a question about whether primary care physicians fit that attending physician definition in many situations. Basically, will they be considered primarily responsible for the treatment of the patient's terminal disease? And we hope to get clarity on that before the law goes into effect. And so we've consulted legislators, legislative counsel, and the California Department of Public Health. When we get clarity, we'll publish widely. It certainly doesn't seem to be anyone's intent to exclude primary care physicians, and we suspect that when we get clarity, it's going to include primary care physicians in that definition. Our best advice right now is to read what we distribute on the law and check on that particular issue when the law goes into effect. So it's a very prescriptive law, understandably, and we broke it down into steps. And I think the other panelists are going to add additional things, steps to consider as you build out your workflows. But this is what's in the law. The first step is to consider whether the patient is qualified. Determine whether the patient can make a medical decision, is terminally ill, voluntarily made the request, and is a qualified patient under that definition on an earlier slide. If there are indications of a mental disorder, the attending physician must refer the individual to a mental health specialist for an assessment. And if such a referral is made, no aid in dying drugs can be prescribed until the mental health specialist determines that the individual has the capacity to make medical decisions and is not suffering from impaired judgment due to a mental disorder. The next step is to inform the patient. This is, again, the attending physician. And this is all in the law. These are not suggestions. Inform the patient of their medical diagnosis and prognosis, the potential risks associated with ingesting the drug and probable result of ingesting the drug. Inform them that they can choose to change their mind. They can obtain the drug and not take it. And there are a couple points in this process when the attending physician has to tell the patient that. And describe the feasible alternatives, palliative care, hospice care, and the like. Step 3, refer the patient to a consulting physician. This has to be an independent physician who must examine the patient and medical records and confirm in writing the diagnosis and prognosis, the patient's capacity to make medical decisions, and that the patient is acting voluntarily. This physician also must refer to a mental health specialist for an assessment if there's signs of a mental disorder. And this physician must document his or her findings and submit them along with a compliance form to the attending physician for the medical record. The patient goes back to the attending physician who must counsel the patient. Counsel them about having another person present when he or she ingests the drug, not ingesting in a public place, notifying next of kin, participating in a hospice program, and maintaining the drug in a safe location. If the patient declines to notify next of kin, you don't have to deny the request for that reason. You just have to tell them that it's a good idea to notify next of kin. Next step is the final attestation and prescription. So the attending physician has to provide a final attestation form and tell the patient that they should fill it out within 48 hours prior to the patient taking the aid in dying drug. Again, at this stage, tell the patient that they always have the opportunity to change their mind. You can provide the prescription and they still don't have to ingest the drug. And then the attending physician can prescribe the aid in dying drug. As in all things in healthcare, there is a requirement that there are a lot of documentation and reporting requirements. The medical record must contain a note of all oral and written requests, the attending and consulting physician's diagnosis and prognosis, determination of capacity to make medical decisions, and determination that the patient is acting voluntarily and has made an informed decision. If any mental health specialist assessment is performed, that should be in there. And a note that the attending physician offered that the patient could change his or her mind, offer that he or she can withdraw or rescind the request at any time. And a note by the attending physician indicating that all requirements have been met, and a note on the drug prescribed. There also should be the final attestation form. Obviously, this is when it's handed over to the patient, sort of out of control of the attending physician, whether they get it back. So we would advise that the attending physician make a note that they gave the form to the patient and that they counseled the patient on how to complete it. Within 30 days of writing a prescription, the attending physician must submit to the California Department of Public Health a copy of the patient's written request, the attending physician checklist and compliance form, and the consulting physician compliance form. And again, we're going to direct you to these forms at the end of the webinar. And within 30 days following the patient's death from ingesting the drug, the attending physician must submit the attending physician follow-up form. And excuse me, within 30 days of the patient's death from any cause, not necessarily from ingesting the drug, from any cause.
The law provides broad protections for you, for physicians, from liability, suspension, loss of license, a lot of bad things. It also prohibits contracts, wills, or agreements from being affected by a request or an ingestion of an aid in dying drug. So the law says ingestion of the drug is not a suicide and cannot affect health insurance or life insurance. It protects people who are present or help prepare the aid in dying drug so long as they don't assist with the ingestion of the drug. Next slide. The law also, next slide, please. The law also protects physicians who want to opt out of this process. So providers can opt out of participating in the law. They can opt out of informing patients regarding his or her rights under the law, and opt out of referring a patient to another physician who participates. And I just want to note, there's obviously ethical, clinical considerations that you have to make here. This is just what's in the law. So lots of considerations outside of the law should go into effect, but the law protects those who opt out. Next slide. Actually, no, stay on, yes. So the law also allows providers to prohibit employees from participating. And so your hospital, for example, can prohibit you from participating while you're on the premises or while you're in the course of employment. That prohibiting provider must first give notice of the policy prohibiting participation. And if it doesn't, or he or she doesn't provide notice, then he or she or it cannot enforce the policy. Next slide. The prohibiting healthcare provider can take action against any individual or entity that violates that prohibition. So you have protection under the law, but your hospital, if it's a prohibiting provider, can cause you to lose privileges, suspend you, if you violate their policy that they've made clear. Next slide.
Oops.
So then we're going to save questions for the end, and I'm going to turn it over to Dr. Regan, who is our family physician colleague from Oregon. Dr. Regan?
Thank you. Hi there. I've been retired since 2011, but in 1998, I was in a very active family practice medicine clinic, which included a large obstetrical practice and many young families, as well as the wide range of generations. I was contacted by one of the original medical leaders in Oregon of the Aid in Dying movement, Dr. Peter Goodwin, who'd also been my teacher and later my friend. He asked me to see a patient who'd contacted Compassion in Dying of Oregon a few weeks earlier who wanted to engage with her terminal illness and death using Oregon's new law. She became the first patient in the United States to receive a legal prescription. Go ahead and change slides. Next slide. I described my intense experience with her and her family in the Lancet article in April 1999. At the time, it was hard to find advice or knowledge about the practice. My wife had helped write the Oregon guidebook to the Death with Dignity law, which is available online. And I also had an informal counsel with Dr. Goodwin. My evaluation of the patient included 2 office visits, a house call, a specialist consultation, as well as a mental health consultation, and then conversations with her previous doctors, hospice workers, and family members. Next slide, please. Filling out the checklist forms from the state of Oregon ensured that I'd fulfilled the requirements of the law. Go ahead and show the next slide. For life-ending medications, the short-acting barbiturates have many advantages. Significant prior usage and thus tolerance is rare. Sleep comes quickly, and the drug has a pronounced respiratory depression effect. And without any controlled study, most doctors pre-medicate with ondansetron and metoclopramide to prevent vomiting. Not that the drug stimulates that, but it just seems really important to make it not happen. Availability and price of the barbiturate has varied over the years, and it is important to check out this aspect whenever one receives a request, as the situation will continue to evolve. Next slide. Since our law went into effect, there have been upwards of 1,800 planned deaths in Oregon, Washington, Vermont, and Montana. These occur in the ordinary course of medical practice. Deaths are routinely attended by family members and often by hospice employees, friends, and others. And their regular medical providers are aware of the requests and have had the opportunity to comment on their appropriateness. These events are no more clandestine than any other medical treatment in the state, and are more thoroughly followed and studied than any other practice because of the mandatory reporting. Disciplinary measures could be driven by irregularities in filling out the forms, or else, of course, by complaints from caregivers or family. But the Oregon Medical Board has reported no significant problems beyond some involving timing issues of form completion. Next slide. Over the years of practice, I wrote something like 25 prescriptions and roughly 15 were used. I personally attended 3 of the planned deaths, including the first one. Since I retired and have become a medical director at Compassion and Choices, I've been involved as a consultant with many more cases all over the state, perhaps touching hundreds of events in some way. It's been more clear that my first case was very emblematic. She was a widow in her 80s with supportive, warm family living in her own home, facing her relentless decline in the face, in her case, of widely metastatic, increasingly uncomfortable breast cancer. It's not that she had unbearable discomfort. It was just that although she had reasonable symptomatic control, she recognized that each day was worse than the last one, and she was already to the point that she couldn't do the things that made her happy. For her, staying alive had become an increasingly annoying duty, and she saw no point in continuing on this path. Really wanted to die consciously and responsibly with her family members present. By the time of her death, she was clearly looking forward to it, and it was equally clear that when she finally drank the medicine, she was pleased with, grateful for, and proud of what she'd done. Next, oh, wait, one more. In Oregon, that's good. In Oregon, over the years, about 15% of planned deaths have been attended by the physician involved. If you are offered the opportunity to attend a death, it is appropriate and well worthwhile to be there. You will find it a deep spiritual experience that is difficult to recreate any other way. Patients who invite their doctors also seem to be comforted by their presence. Next, wait, leave that one. Well, we'll hold that one for a while then. After describing my typical case, it's important to mention that the law does not help with all the problems. Yeah, it's the next one. Show the next slide. Yeah, does not help with all the problems around maintaining dignity at death, most especially the law does not apply to patients with dementia. But what the law does do is really opens the conversation about death, and in that setting, it's much easier for families to begin to work through their own issues around it in a much broader context than a simple discussion of aid in dying. Sometimes you'll be asked for help by a patient for whom you will not want to prescribe for whatever reason. If this is temporary reason, such as being unclear about the prognosis or not comfortable enough about the current family dynamics or mental health, this unease can be addressed with further diagnostic tests, follow-up visits, consultations, or conversations with others involved in the care of the patient, always, of course, accompanied by efforts to optimize palliative care. Next slide. There are many cases in which a requesting patient will not qualify to use the law but still have a respectable reason to end their life that you sympathize with. And it's critical to have a plan B in mind. Sometimes discontinuing treatment is a viable choice, such as when a person's on dialysis. But there's usually only one other voluntary stopping, there's only one other legal death hastening option available, and that's VSED, voluntary stopping eating and drinking. This option is very underappreciated. Next slide.
There you go.
Yep, there you go. That's the one. Very underappreciated. Hospice data and my own clinical experience shows that VSED can be a very humane, dignified route to follow, and since it can take significantly less time than 2 weeks, it is usually quicker than AID as practiced in authorized states. To be able to fully address patient requests for aid in dying, it's very important to be familiar with and open to this choice. Of course, the rate limiting part of VSED is in stopping fluid intake. It's beyond my scope here to describe this in detail, but anyone doing end-of-life care would do well to learn a lot more about this age-old technique. And dying on the dry side has important palliative advantages: decreased edema, better respiration, less need to eliminate, etc. In fact, at the end of any life, a good mantra to remember is die dry. Sometimes patients want to exclude an unsupportive family member from the discussion. This is really fraught. That family member will eventually experience a suicide, even though the actual event may be an inspiring planned death. If it is absolutely not possible for a family member to be informed, then it is critical that the patient provide some form of recorded discussion or farewell that can be seen after the event to help them deal with what they will perceive as trauma. Next slide. We in Oregon did not know at the onset what the medical complication rate might be for medical aid in dying. At this point, we can say that once a patient has ingested lethal medication, the median time to death is in the range of an hour, but about 15% remain alive longer than 8 hours and 1% beyond 24 hours, and some may actually appear to begin to regain consciousness. While the very few who have reawakened seem to have regained normal consciousness, much like we usually experience with drug overdoses and suicide attempts, we do not have enough clinical experience with recovery from these to be able to be reassuring about this. Since a more prolonged dying process is not exactly rare, it's strongly recommended that any patients planning to ingest aid in dying medication should discuss this possibility and their wishes about what should happen if they start to reawaken. These discussions need to be documented and need to be available to anyone who may be making post-ingestion medical decisions. That person or agency needs to be aware of the patient's plans and be ready to continue care if necessary. The most common outcome is some form of palliation. So to summarize, there's going to be some demand for this service. It will not be numerically overwhelming, but some individuals' cases will be very compelling and likely to convince you that the choice is right for them. Next slide, please. Some patients will feel that they've won a right to access to this practice. This is not quite true. The law only gives you, family, and friends the right to decide to help them. Our first goal is to work with patients to help them optimize their dying process, which may or may not be best served by medical aid in dying. They need our openness, but also our perspective and counsel. Without personal openness to all options, we can't credibly help them think through their choices. It's really critical to appreciate the value of permission to discuss these issues. Without legality, it's a huge favor for a patient to ask their doctor or their family to discuss breaking the law. If asked, you now can explore these issues without fear of legal consequences, so the conversation can be more real. Use this freedom to ask others around the patient how they feel about the request. Next slide. Remember that making a request is something a patient has thought about for a long time. It's important and deserves a considered, respectful response. Also remember that denying a request or even postponing addressing it has some potential to lead to violent suicide. It's far preferable for patients to remain with their own providers through the process, or at the very least with a referral system that's part of their system of care. All patients feel that the process is arduous, but it's much less so when their own doctors carry it out. And I mentioned already, there is a good Journal of Palliative Care article by Orentlicher, Pope, and Rich on the clinical practice of aid in dying. It's really important that family and friends be involved in discussions of this choice. This is something that they will know after it happens, and it's much better for them to know before it happens. It's important to have a plan B in mind for people who don't qualify, and most commonly this may be voluntary stopping eating and drinking. One possible outcome of the use in aid in dying is a prolonged dying process, and patients and families should be made aware of this, including discussion of possible next steps. Next slide. Almost all aid in dying patients in Oregon and Washington are enrolled in hospice programs. Palliative care programs and hospices have the explicit mission to neither hasten or prolong the dying process, and the goal of care is comfort. Those of us that have written prescriptions know that acceding to a request for medication for aid in dying brings considerable emotional comfort and relief from anxiety, and that is never the caregiver herself who hastens the death. It is the dying patient acting on their own. Thus, for mentally capable terminal patient who clearly requests it, aid in dying is consistent with the goals of palliative care. Finally, this next slide, please. In life, we have learned that we achieve the best outcomes when we're looking where we're going.
Thank you, Dr. Regan. And next, we have Dr. Keef from Washington.
And can you hear me well?
Yes.
You can.
Good. Well, hi, I'm Greg Keef. I'm a family physician in Washington State, and I spent approximately 20 years in full spectrum family medicine. But in the last 5 years, going on 6, have shifted my clinical practice fully over to hospice and palliative medicine. So I have had quite a number of patients, dozens of patients, raise questions about physician aid in dying with me. However, unlike Dr. Regan, I'm in a slightly different situation in that I work for Providence Health and Services, which is a Catholic healthcare system, and so by my employment agreement, I'm not allowed to materially participate. However, that doesn't in any way diminish the nature of the conversations, and that's what I'll really wish to focus on today. Next slide, please. But I'll start with a little bit of background information, and I'm going to be reporting on Washington State's latest data, which is from the year 2014. I will say nearly all of the data that I'm going to present here is almost perfectly paralleled in the Oregon experience. They have many more years of experience, but when you really unpack the data between Oregon and Washington, the law has been implemented and utilized nearly identically in the two states. So in the year 2014, 176 different individuals received prescriptions for lethal medication. 170 out of them died. 126 ingested, 17 from natural causes, 27 unknown. That means about 72% of the people who received the prescription actually ended up taking it. That's actually a slight bump upwards. If you look back over the years in both Oregon and Washington, it's been roughly 2/3 of the people who receive a prescription take it, and about 1/3 never do. Now, a question that often comes up is, well, what happens to the medications for the people who don't take it? And at least in Washington State, the advice people have been getting, and I'm betting that this is similar in Oregon, is to not actually fill the prescription until the day before or the day of the planned ingestion. And that's twofold. Number one, if you're a part of that 1/3 of the people who decide not to take it, which is a substantial number, you're not introducing those medications outside of the pharmacy setting or outside of the controlled setting. And secondly is just the expense. Dr. Regan mentioned some of the access issues, and pentobarbital recently has not been accessible at all, and the secabarb can range anywhere from a few hundred to a few $1,000s all told. And so Most patients, when they receive a prescription, are being advised not to fill it until the day of or the day prior the intended ingestion. And then there are some individuals who don't know. I'll pause just a moment to go back and also highlight Washington's bill was approved. It was a citizens initiative, as was Oregon's law that was passed in Washington in November 2008 by a 58 to 42% margin that passed in about 30 of 39 Washington counties. The 9 that didn't approve it are sort of predictably in the politically red parts of the state, if you think of the blue-red political divide. But interestingly, a large number of the so-called red counties also approved the bill, so it had very strong support. That took effect on March 5, 2009, so we'll have 7 years of experience going on here in a couple of months. Next slide, please. This slide is just a graphical representation of Washington showing in absolute numbers, not percent of deaths, a gradual but significant continued rise in the number. Up until 2014's data was almost perfectly leveled off compared to 2013's. If you look at the 20 or so years in Oregon, you'll see a fairly comparable, slow but steady upward trend. When you look across the board, anywhere from 0.1 to 0.3%, so anywhere from 1 to 3 deaths out of 1,000 in the states of Oregon and Washington are via the Death with Dignity Act. So the other 997 to 999 deaths out of 1,000 are by natural causes. Next slide, please. This just breaks down a little bit about the people who utilize the law, and this data comes out of the mandatory reporting forms that Leah talked about in the beginning part of the slide, or in the presentation. By completing this, Oregon and Washington have been able to aggregate a fairly substantial body of data. So nearly over 2/3, nearly 3/4 of the people who utilized the Death with Dignity Act in Washington had cancer. A disproportionately large number have neurodegenerative disorder. And what I mean by that is the percentage of people with neurodegenerative disorders dying via the Death with Dignity Act is greater than their relative proportion of overall deaths. And there's some thinking that somebody with ALS has to sort of make the decision earlier in the course of the illness, because if they wait too long, they will lose their ability to self-administer. And so they can't hold out as long as somebody else might be able to and say, maybe I will, maybe I won't. They're sort of forced into a decision earlier. The demographics, the age range is quite broad, 21 to 101 years old. I believe it was the 2013 Oregon report indicated that in all the years in Oregon, only 6 people under the age of 35 had utilized their Death with Dignity Act. And the overwhelming majority, well, I should say more than 50% are people between the ages of 65 and 84. So very clearly, if you're thinking about this sort of distribution curve, the peak is going to be in the 60s to upper 60s to early 80s. It's been about a 50-50 split between men and women. In 2014 in Washington, women 57% compared to 43% men. Most years it's slightly flipped, where slightly more men than women. Washington is a fairly Caucasian state compared to California, certainly, but even beyond that, 92% of the individuals who utilize this are Caucasian, and that's more strongly skewed towards Caucasians than the state's population in general. Over half were married, 3/4 had at least some college education, and 95% lived west of the Cascades, which is where Washington's population is concentrated, and a little more politically progressive environment. Where these demographics are important is some of the most worrisome things that people had raised in opposition to these laws were, will this adversely affect the most disenfranchised? Will minorities, the disabled, the socioeconomically disadvantaged feel pressured into utilizing these laws? And in fact, what we're finding is more the opposite, where it tends to be chosen by people with higher education, better economic resources, and so on. And so now there's actually become discussion, is in fact the social justice aspect more the opposite, that the disenfranchised won't have access to the option in the same way those that are more privileged would, as opposed to the previous social justice worry being, are the disenfranchised going to feel compelled or pressured in some way to utilize this? Next slide, please. Of those who utilized the Death with Dignity Act in Washington, 92% died at home. And here that really means home, 5% in the long-term care setting. And so this is not something that is a significant issue in nursing homes, adult family homes, assisted living facilities. It does exist, to be certain, in some of the more challenging social scenarios I've seen played out in long-term care, because they all have to have their own policies and procedures. But this is far and away most commonly done in one's own home. In 2014, 0 deaths occurred in a hospital. In the first 12 to 15 years in Oregon, only 1 death took place in a hospital. So when the law took effect in Washington, there was a lot of press about which hospital systems that they would participate, which wouldn't. That's far less about people utilizing it in the hospital than it is about employment of physicians. And so because I'm employed by a Catholic health system under the auspices of my employment, I may not participate. Now, if I was in, say, a half-time position, our law is written that I would not, my employer could not prohibit me if I had, say, a 0.4 position in a completely independent arrangement. They could not prohibit me from participating there, only under the umbrella of my work within our employment agreement. And so that was codified when Washington passed their law. In 2014, only 68% were enrolled in hospice, and that number's down. It's normally in the upper 80s and low 90s. You see it was 86% in Washington in 2013, 93% in Oregon. And by the statute, everybody needs to be offered the full range of options, including aggressive pain management and other symptom control, hospice, palliative care. So all people were offered hospice, assuming that the providers were in compliance with the law. But over 30% in 2014 chose not to enroll, and I don't think we really understand that one yet. The overwhelming majority have some form of health insurance, and that includes Medicare or Medicaid. Most years there's 0% with no health insurance. In 2014, 2% of the Washingtonians who utilized the law were documented to have no health insurance, and then a 5% it was unknown. The lower set of bullet points I think here is really critical, because many people worry that the major driver is inadequate access or inadequate quality of hospice or palliative care. And that has not been the experience in Oregon and Washington. Far and away, issues of self-determination, the concepts of how one defines autonomy, how one is able to participate in the activities of life that make it enjoyable, their conception of dignity, those are all up 80%, 90%, 94%. And those are the things that are very clearly the drivers and have historically been the drivers in Oregon and Washington. Inadequate pain control or concerns about it were cited as a significant concern by 40% in Washington, but in some Oregon data, that number is anywhere from 5 to 25%. And so I think most of the people who are following through with this know full well that through aggressive palliation, all the way up to and potentially including palliative sedation, they have non-lethal means of achieving symptom control. And so that's not the big driver. The big driver continues to be self-determination issues. Next slide, please. Now, slight shift. Back in 2004, Susan Toll and her colleagues at Oregon Health Science University did a fairly innovative and extensive qualitative research study where they interviewed dying Oregonians and did a range of questions. What came out of that is about 1 in 200 individuals with a terminal illness in Oregon considered PAD as an option. About 1 in 25 actually made a request to a healthcare provider, and that could be anybody from a hospice chaplain to their attending physician. But less than 1 in 600%, or less than 1 in 600 individuals actually followed through, so slightly less than 0.2%. That middle bullet point to me is one of the most crucial things we need to understand, which is regardless of whether we're pro, con, the availability of aid in dying, regardless of whether we're participating or non-participating physicians, our responsibility is to provide the best care possible to all 25 of those individuals who make an inquiry about the Death with Dignity Act. To not get so hung up on the 1 on 25 who eventually follows through, that we lose the opportunity to really serve all of the individuals. And you can see if we do that well, 24 out of 25 will not follow through. And I think if we really do our jobs well, we can maybe change that number to 1 in 50, 1 in 100. And the critical piece is that we need to respond to all 25 as openly, compassionately, and in as patient-centered a manner as possible. Next slide, please. So when people bring up the question of physician aid in dying, we want to understand their story. Where does this illness fit in sort of their life's narrative? You think about the concept of narrative medicine, the story they've already written, but the draft versions of the future chapters, and where do we fit within that? Where does this illness fit within it? This gives us a rare opportunity as physicians to be able to really fully invest ourselves in caring or healing rather than worrying as much about cure. Obviously, cure when we can, but heal and care always. And then we can actually play a facilitating or guide role as people go through these experiences. And I would add here, remember when people ask about the aid in dying law, that they are not simply looking to hear what you have to say in response, but they are very closely reading us as physicians in terms of how we respond to their request. And if we respond in a way that indicates our own sort of disapproval, our own discomfort, that may well shut down conversation. It may even further impact the nature of the therapeutic relationship between us. So whether we're for or against, pro, con, much of what we do on the front end upon the initial inquiry should look no different, because we're still trying to, regardless of where we fit on that continuum, provide the best care possible so that they, at the end of the day, feel their needs were met with or without utilizing a lethal prescription. Next slide, please. And so that does require a little vulnerability on our part, and really being willing to enter into the patient and the family's values and goals, becoming part of their story, and really, as Peter said in the first earlier section, these conversations are never light conversations. You go fairly deeply, fairly quickly. And I've found some of the conversations when people raise these questions to be some of the most profound. Now, often they're using this as sort of a bargaining chip, if you will. The very first person that asked me about it on the day the law took effect, at the end of our discussion, and I determined by then that she wouldn't have qualified anyway, she looked at me and said, "You know, doctor, I would never do this. It doesn't fit with my beliefs, but I wanted to make sure that my family understood just how badly I'm suffering." And then that really opened up a lot of conversation with her family. Next slide, please. So where to start with this, the first thing is by asking questions. When a person brings this to us, it's tempting to start by saying, well, I work for Providence Health and Services. I will be there for you every step of the way, but I'm not allowed to participate. But if I start with that, I am shutting down a lot of opportunity for deeper conversation. Or if somebody asks, I could immediately get into citing all the requirements of the law that Leah went over earlier. Well, you need to ask in writing, we need to fill out these forms, 15 days apart, you need to make a second oral request. But by getting so deep into the technical weeds so quickly, once again, I'm sort of bypassing the opportunity for the deeper and more meaningful conversation that these requests really present to us. So before talking, before telling, start with critical questions. You've asked me a very important question. Before I answer, though, I would like to learn more about what led you to ask me about this. Would it be okay if we talk about that further? And that last part is important as well, because that returns agency to the patient. They can say, yes, I would like to talk about it. They might respond by saying, you know, I've already talked about this with everybody at counts. I just want to know the details of the law. But we find out what they're looking for by asking. Another key question, what do you understand about your situation? Really find out if there are misconceptions that be corrected, if there are easily treatable scenarios, if it's just, you know, anxiousness about what might happen, that maybe some knowledge would actually help allay that anxiety. Knowing what you know about your situation, when you think about the future, what are you hoping for? This really opens up a wide array of ways in which we can respond in the most helpful way possible. What is most important to you in the time you have? What can we do to best help you live the life you want to live? That last one, when I work with terminally ill patients, one of the greatest compliments I received a while back is a nurse said to me, you know, when you have these conversations, I'm struck that you don't talk much about dying. You spend all your time talking with the patients and their families about living, how they can live their life, how they can best live their life. And I think that's an important frame shift. Patients and families want to really talk about how we're going to help them live the best they can for whatever duration of time they can, rather than focusing in on death in and of itself. The resource at the bottom of this slide, a new email just went out today from the American Academy of Hospice and Palliative Medicine. AAHPM is sort of the hospice and palliative medicine counterpart to the American Academy of Family Physicians. They have posted at the website listed a position brief which advises people on steps to take in the event that somebody raises this question. And somewhere in the next matter of weeks to maybe a few months, they will also be updating their position statement on physician aid in dying. So next slide, please.
Sorry, I have a crazy mouse here.
Okay. So the last two slides in my section are actually sort of a series of bullet points on how to respond to requests for aid in dying. Now, in a very timely publication yesterday, the Journal of the American Medical Association, JAMA, electronically posted an entire theme issue on end-of-life care with a lot of focus on California's End-of-Life Options Act and responding to requests for physician aid in dying. And so one of the articles is by Tim Quill, the lead author of the article referenced on this slide, as well as Tony Back and Susan Block. And their article is called Responding to Patients Requesting Physician Aid in Dying, Physician Involvement at the Very End of Life. And so it's in the January 19, 2016 issue of JAMA, the Journal of the American Medical Association, starting on page 245. So I would refer that to you. But this slide, the next one, just really focuses on a very practical sort of procedural way. Clarify the questions, support the patient at every step of the way, evaluate their decision-making capacity, making sure they understand what they're requesting, explore all dimensions of suffering. It may be that a chaplain is going to be the most important person if a patient's experiencing significant existential distress. Recognize and respond to our own emotions as well as the patients and families and the caregivers. Really focus intently on the best medical treatment possible. This should never be done because we've failed to provide adequate symptom control. You know, there are times the symptoms are just simply beyond our ability to control, but we should never not try. And then really to respond to the request does require a multidimensional evaluation. Next slide, please. And then subsequent to it, really take the time to reflect on your own feelings, talk with others, seek consultation. I remember Susan Block doing a session on palliative sedation where she said, how many of you are comfortable with palliative sedation? And a few hands went up and she goes, I don't know if you should be. What we're doing in that situation is profound, and maybe a little discomfort should be second nature to it. That doesn't mean you shouldn't do it, but it should cause you to pause and seek the guidance of others, to not be out on your own doing this sort of things. Really consider the alternatives. Dr. Regan spoke about voluntarily stopping eating and drinking, palliative sedation where you use something like Ativan, or not Ativan, but Versed, perhaps phenobarb, to intentionally sedate a patient to unconsciousness for their last hours to days of life. You know, there are different options besides following through with a lethal prescription. And then really balancing one's own conceptions of personal integrity with our professional obligation of non-abandonment. And with that, I will pass the baton to Kat Forrest, who will talk a little bit more about preparing to respond to the End-of-Life Options Act in California. Kat?
Hi, thank you. Thank you, Greg. I'm Catherine Sonquist Forrest, and I am in the California setting, which is our onset of our laws at such a different time. So if you just go to the next slide, please. I just want to point out that it's very interesting times because right now there are these laws being introduced in so many states across the nation. There are campaigns in many states across the nation. So although there are only in the thousands that have been done, have been completed across the nation, the times are changing rapidly in terms of national acceptance of the concept of this within the medical arena. And we know from the study at UC Berkeley that that there's a widespread support within our own state in California. So it'll be interesting to see how it plays out as it is launched sometime during 2016. We're not sure exactly when. And I'm intrigued by the concept of how it will be interpreted with regard to family doctors, since we have the same language as Oregon concerning the language of attending physician. And we know that the intent was certainly not for patients to have to seek a new physician for terminal diagnoses or determination of end of life. Similarly, we already know with hospice that family physicians are engaged in determining terminal diagnoses for hospice purposes already. So we'll be watching carefully, and I know the CAFP will provide that information as soon as we have it. But the purpose of this slide is just to show you how many states currently have bills, how many have been completed, and how many campaigns are underway. So many people, as we watched Oregon and Washington initially, many people have their eyes on California as our law rolls out. One thing I wanted to point out is that the term adopted by the laws currently is the term physician aid in dying. This term is the sort of the medically accepted term by laws and professional societies. When a physician prescribes a lethal dose of medication to a mentally competent, terminally ill individual upon the patient's request for the patient intending to end their own life. And the American Public Health Association has pointed out that it's important to remember the reasoning, which is that their judgments are not impaired by mental disorders, and therefore it's fundamentally different from reasoning than a clinically depressed patient using to justify suicide. Therefore, it is not physician-assisted suicide or euthanasia. Euthanasia is a third party administering a lethal dose, and it is illegal, including in California. Very important, and that's to note those differences in our law. Next slide.
Oops. Sorry, Kat.
Catherine, thank you. I appreciated the acknowledgement that so far most of the deaths have occurred at home, a majority still in hospice care, but not all, and that those decisions about when someone is not in treatment but is instead choosing not to prolong their life but to hasten death are mostly occurring at home. And I won't belabor this. I really appreciate it that the law, we've gone over the law, that that this process takes time, and that people are mostly at home requiring us to be involved in their care, either in hospice or palliative care during this time. One thing I wanted to note in terms of California is that we've learned so much from the Washington and Oregon experiences, and I'm very appreciative of the generosity of those that have gone before us in training us. So in California, I'm noticing that we're having primary care and palliative care and hospice together doing these trainings because our patients are moving more equally between us. With the new billing procedures for end-of-life planning, we can actually bill to have these conversations. We can have the conversations in many different settings. It can be in the hospital, they can be at home. It will be really, really important. And in my own experience of training, I chose to directly work to train primary care physicians alongside with our palliative care physicians so that we could have those options available and with ease at the physician level and referral level as well as at the patient level. Next slide. One thing I'm asking as we're doing training is for physicians to go through the process ourselves, to think about our own end-of-life plan. This was raised at the UCSF conference on the End of Life Act as a way to clarify and to to allow people to be present with clarity at the time of requests. So I put it here just as a placeholder for people on the webinar to think about in training. When I trained the primary care physicians across Stanford last week, it turned out that less than 15% of our physicians had done this for themselves. That's fairly dramatic, and I think it'll be interesting to see whether or not, as we push the needle forward on this, whether or not that assists people having some knowledge and comfort in training and in being present with our patients as they're doing some planning for themselves around end-of-life options. All right, go ahead into the next slide. So what we've focused on, again, I don't want to overlap, but I think that it's important to look at what the options, how do we go about this, expressly because the California law so emphasizes the concept of what are the options. Even the name of our, hello? Am I still on?
Yep, you're still on.
Sorry, I lost it from my side. Especially because even the naming of our act specifies end-of-life options. So it's in the context of those 24 out of 25 that Dr. Vandekeep pointed out. It is, people may ask, but what they're really asking for are, what are my options, including physician aid in dying? So what we're using this as in our setting, and I think it would be a great across the state to do this, is to re-up our individualized training in primary care and in family medicine to think about this as one option and increase the training across our profession to talk about the options. So just as that ask, tell, ask model, what do you understand about your situation? Is it okay to talk about that? What are you hoping for? What's most important to you in the time you have? And then go to clarify what the request is about so that we can really go into what is the nature of the request, exploring the suffering and the fears, what is the root cause underlying it, and then to explore your own biases. The third piece of this is really to affirm our commitment to care for the patient and his or her loved ones. This is particularly important in family medicine. At the point of this request, people have often been struggling at the fragmented nature of our system, particularly around terminal illness. There's multiple specialties involved, and they may be looking for just a landing place. They're feeling isolated and frightened. And we can really explore what the nature is of their fears and their suffering. This is also looking at the root causes, an opportunity to explore depression. And this is critical to the intent of the law in California, to really pull apart whether or not the person has mental competence and whether or not we have an undertreated depression going on here, since many constitutional symptoms could be symptoms of depression as well, and assessing for hopelessness may be part of what you're doing here as well. So that's really important. Our law specifically includes consulting physicians, but in the context of the patient-centered medical homes that we've developed, this is an ideal opportunity to develop the networks for consultation also with colleagues from the perspective of attending physician. So that's one of the things that we're hoping that as the implementation goes forward, that people are not isolated in these requests as well. It certainly is not the intent of the law. And then the last one is actually to consider providing the care for an individual patient, evaluating from your own value system if you are participating, or if you're not participating, but you're okay with referring, you could go ahead and refer the patient as appropriate. The law does not, it's not a right under the law to get access to physician aid in dying, nor is it a right for an organization to provide the physician aid in dying. There's nothing that requires a patient to have access. This is not an access law. And it'll be interesting to see unlike other medical procedures, how this plays out. There are groups within this that are interested in making it possible for patients to find out who is participating and who is not participating, not dissimilar, for instance, to abortion services, but it's not clear how that will play out in the state of California with regard to the law. Next slide. Currently, the state is setting up some information for us to get detailed support. Specifically, the End of Life Options Act free hotline is already in action. That's the second line there, the 800 number, if it's for terminally ill Californians, but also physicians and pharmacists. This is the official hotline available for our End of Life Options Act. The number that are on the top and the bottom are being put together by the End of Life Options Group. This is a support group for people that are participating. It's not for non-participants, it's for participants specifically on our law and the details of how to prescribe and to be in compliance with our law. So I wanted to make those available for those on the call that are choosing to participate, but make it very clear that this is not it's not a requirement to participate, and that information that for non-participants, both organizations who are protected very broadly, and for organizations and for physicians that are not participants, you're protected very broadly, and the details of that will be available at the End of Life Option free hotline. And I expect that the CAFP also on our webpage, which you'll see at the very end, we'll provide very neutral and important information on how to best support our patients and each other in making choices about how to best engage around this new access, end-of-life options of physician aid in dying. Next slide. Light at the end of the tunnel. Here's a few last things to consider. One of the things that we've been working on in our group is to really engage our patients actively in preparing to meet with us. There's a few initiatives that are patient empowerment initiatives to bring to physicians. Some may be familiar with the Conversation Project. This is a link to get patients to think actively about end-of-life planning and how to have these crucial conversations about what it is that they desire. And it's not specific to physician aid in dying in any way, shape, or form, but again, in the context of all choices, this is an important conversation. I think Dr. Regan pointed out that really if you have each person involved in a family, it's a much better experience. If there's one person who experiences physician aid in dying as a suicide, it can be very hurtful for those that go on. The Conversation Project really facilitates those crucial conversations amongst family and friends. The Letter Project at Stanford specifically is oriented towards physicians bringing these conversations to their physicians and then enabling the conversations at the end-of-life planning visit. It also, embedded in it is the ability to do things like the PULSE form, and embedded in it is the ability to do the Durable Power of Attorney for Healthcare form. It's also, but oriented more towards physicians, patients orienting the conversation when they go talk to their physicians. The next several are articles that have actually already been referenced, and they're just helpful for the perspective of physicians thinking through their own sentiments, perhaps ambivalences and understanding. The clinical criteria article was actually the 2008 clinical criteria article, the 2015 clinical criteria that just came out, and it is available. It will be available and posted as a link. I did want to point out that the CAFP is planning at the 2016 Clinical Forum in San Francisco specifically to do very targeted training for family physicians on these crucial conversations. So when faced with a request, how to engage very practically around the request for physician aid in dying, and then also how to include all of the options: palliative care, hospice care, physician aid in dying, combinations of those, sequential perhaps treatments, and then also specifically how to have those last conversations that are required by law in California, such as that you could rescind that request. So very specific both to California, but more generalized end-of-life options. And then the last one to look forward to will be sample conversations, which will be posted probably on YouTube, but also through CAFP, and a plan for the CAFP to work on a maintenance of certification part 4 for this crucial thing, the end-of-life planning, which is emerging as a critical skill set for family physicians across the country, not just in California. As I pointed out at my first slide, there are initiatives around physician aid in dying, but also coding for Medicare and a move as we have increased access to palliative care, neither hastening nor prolonging death, and increased access and acceptance of hospice and an aging population, that being able to consider and engage around all choices for different kinds of patients and diagnoses is certainly one of the most important, and as important as birth options might be for a family physician today. So I leave you with that notion. If you last slide, this is the CAP education and resources. This is a picture of our current web page of where will be changing as the different options come available to you. And I think perhaps one of the others wants to speak more specifically to this. Thank you so much.
Thank you to all of our panelists. Thank you, Dr. Regan, Dr. Keef, and Dr. Forrest for those wonderful presentations. We certainly appreciate it. And we, as Dr. Forrest noted, we have built this resource center. It has information on the law, but it's also broader than that, and we'll have an upcoming podcast that we're developing, other webinars, this webinar, Maintenance of Certification Part 4 program, lots there. So we invite you to look at those resources that we're developing. We will distribute the slides to all participants, and I think we'll also distribute an article on the law that CAFP has drafted that has links to all the forms that are required under the law. And we're going to open it up for questions. I want to invite anyone who is feeling shy to use the chat box. If you move your mouse to the bottom of the screen, you can use that. I see already 2 questions about the law itself. So as we noted, the patient has to make a written request in a specified form, and the first question is about the 2 witnesses who have to witness that request. Can one be related and one be a part of the healthcare, be a healthcare individual is the question, and that is correct. It's noteworthy that only one witness can be related or be entitled to a portion of the requesting individual's estate upon death, and only one can own, operate, or be employed at a healthcare facility where the patient is receiving medical treatment or where the patient resides. So that's the language from the law. And I see a second question there. Is there a specific definition of capacity that must be addressed, patient capacity? And yes, there is. And this is, again, language from the law. The patient has to have the ability to understand the nature and consequences of a healthcare decision, understand its significant benefits, risks, and alternatives, and make and communicate an informed decision to healthcare providers. So that's the capacity to make medical decisions. I see another note that the call numbers that Dr. Forrest shared are run by Compassion and Choices, and we should definitely acknowledge that group and the wonderful work that they do, and that they're designed, just as Dr. Forrest noted, to help California physicians, pharmacists, patients, and everyone to understand this law and how to comply with it, and how to utilize the end-of-life options now available. So I think we'll open the line and see if there are any questions out there. And again, feel free to use the chat box. Okay, I see another question in the chat box. Do we have any information on what larger groups like Kaiser or Sutter plan to do? I do not. Dr. Forrest, do you have any response to that?
I just word of mouth that they do not tend to block. They're not intending to limit their physicians. So it will be like any other medical practice, where it will not be apparent from the outside who's participating and not participating. The same thing is true for the academic centers to date. I know the same thing is true for the UCs and for Stanford, so that it will be up to providers to make their own decision.
Thank you.
This is Greg Van de Keef. I might just piggyback on that by saying, in Washington, Group Health Cooperative, which is an affiliate of Kaiser, and in fact Kaiser is now going to take over Group Health, developed a program by which they had trained mostly social work conversation facilitators, that when somebody within their system, and it's like Kaiser, a closed HMO, they would get referred to people who'd gone through special training in how to have these conversations. They deal with the added complication. They're not only a healthcare delivery system, but they're the insurer. And so there's a greater potential for internal conflicts of interest. So they really felt like they needed to set a program up accordingly. And I would presume that Kaiser would follow a very similar model.
And this is Pete in Oregon. And Kaiser and Oregon Health Sciences University are the two institutions in our area that have been the most responsive. And I think one thing that Kaiser's done, Kaiser has a very carefully designed system here that just is a lot like how Greg described it in Washington. One of the things, the interesting things that they do is that they contract out their consulting opinions, so that there's always one doctor outside of Kaiser that agrees that a person qualifies, which has worked fine in Oregon over the whole time.
That's an interesting note. I think the consulting physician under the California law has to be independent of the attending physician. So that might complicate things for large groups like that. Any other questions?
This is Johanna Meyer-Mitchell in Concord, California. Does that mean that you cannot refer to your partner to be a consulting physician?
I believe so. I believe so. I think I want to get clarity on that, and when I send the slides and article, I will clarify, but my understanding is that the consulting physician has to be independent of the attending physician. And yes, I think that would mean not a partner.
I can make a comment on that one too. There is a lot of precedent for this situation in Oregon and in Europe, and it's generally considered better. I mean, as opposed to, it's not prohibited in Oregon, but it's sort of generally considered better for the two doctors not to be in a specific business relationship. Now, two doctors both employed by Oregon Health Sciences University that employs thousands of doctors who aren't working in the same clinical setting, who are never talking to each other, accepting over referrals back and forth, who are functioning just like two. That kind of relationship is a little different than somebody who works down the hall from you. But most people in the world who do this actually feel that it's ideal not to have a close relationship with the consultant.
This is Greg Van de Keef again. Just to add to that, one practical implication of that is that it may prolong the timeline from the point of first inquiry to the person actually having the prescription in hand. In the urban areas of Washington, such as Seattle, they've been able to go through that process typically in a little over 2 weeks. But people who are in other areas where they have to go through an organization like Compassion and Choices, or here in Washington, they're now calling it End of Life Washington, get referred to a consulting doctor because they don't have access right away. That can actually extend things out. One husband told me that his wife took over 6 weeks from the day they made the first request until they had the prescription in hand. And so it's just a practical thing to be aware of.
I have a question in the chat box. Any word on insurance coverage for the aid in dying drugs, or on Medicaid coverage? Any responses to that from our panelists?
Well, in Oregon, the Medicaid does cover, and they have carved out money that does not come from the federal government. The significant issue is that the federal money cannot cover the cost of aid in dying at this point. And so, for example, Medicare does not cover the cost of the drugs or any of the appointments or whatever. And I can't comment. I don't know specifically about private insurance. It depends. And I would say on the average, they're not really likely to cover. So Medicaid, yes. Kaiser, yes. But say Blue Cross plans, usually not.
And the other aspect of that as well is that the federally employed physicians, so those working for the VA, will be prohibited from participating, even independent of coverage. So I also live near Madigan, which is an Army medical center. Anything that is directly connected to the federal funding can't directly participate.
And in that sense, it's not dissimilar to other things that have conflicts. For instance, this is a restriction for medication abortion right now. It's the same restriction for that medication. And so there will be, we don't know what the workarounds are, or if how we'll deal with them. I think it'll be as chaotic as for that medication. Mifepristol.
It certainly seems like we'll learn more on that issue. The law definitely doesn't cover that. It does state that commercial plans cannot provide information about this option, that they have to wait for patients to solicit information from them. But other than that, I think we're not sure right now how that landscape will, how that will play out in California. Any other questions on the line, or feel free to type in the chat box? Okay. Hearing none, I want to again thank our panelists for their terrific presentations. We really appreciate this at CAFP. We will mail out the slides and the article with links to the forms. And we really want you to go to CAFP's End of Life Conversations website and to check out the resources available there. We thank everyone for participating and look forward to our next webinar. Thank you, everyone.